went through a phase where, yes, surgery was exciting, and then I went through a fairly large part of my career where I thought, what's the benefit of surgery at all to even, resectable patients? But I have to say now that surgery has improved, the recoveries have improved, I even see the value of that even in patients who relapse later, that there is a survival advantage to surgery. So I've kind of come around myself on the role of that.
I don't know if this is going to hold true, but certainly the data presented today showed that patients who had surgery and went on the APAC, the Adjuvant pancreatic cancer trial, had, even those who went on both arms essentially, did much better than historically patients have done. And the optimistic view of that is that we're doing something better. Yeah. It's not a fluke. Yeah. That they're either the surgeons are better, the medical oncologists are selecting patients better, we're scanning better. But I think it gives more confidence, to me at least, an optimist, that that's real and that we're doing a better job at removing tumors from patients who have them.
Allison, let me tag you on that about, you jumped to that trial. So let's talk about that study a little bit. I personally was disappointed in the results of that study, but review it for us and what it showed.
So this was a large phase 3 study in patients that underwent resection, randomizing them to gem, nab-paclitaxel versus gem alone. And the buzz going into this study and the hope was that it was going to be a positive study and to have another standard of care in the adjuvant setting. However, unfortunately, it was a negative study. And what Paul just mentioned, which was the good that came out of it, is that the survival times for both arms were higher than what we've seen all along. And
what was the number? I forget it.
It was.
I remember it.
Yeah,
So it's around 18 months.
18 months.
For time
yeah.
to progression or progression-free survival.
So both arms. So it wasn't better to add the nab-paclitaxel?
I think it was like
It
18
wasn't.
and 19.
And so you may ask now, what do you do for a patient who can't get FOLFIRINOX in the adjuvant setting? I have been giving gem and cape, and that's my standard. And I was wondering if this was going to change it, but it didn't.
Yeah, so for me, you guys are too young to remember that 5-FU is still the best drug, and it's really the only one that's consistently been shown in the adjuvant setting across a lot of our GI cancers, right? And so this was a fluoropyrimidine-based trial, and so I think Jim Cape is still quite a legitimate choice.
And I think the primary endpoint was independent review of disease-free survival. And there's a big discrepancy between what was found with independent review, a central review, looking just at imaging, and what was recorded by investigators. The investigator reported disease-free survival was much shorter. And the thought was you didn't want to have the bias of the investigator potentially that things were more favorable. There's absolutely the opposite. And some of the thought is that if you have a central review, in the absence and the vacuum of just the image, are you able to truly capture these questionable cases of potential progression? And the clinician, the investigator that has CA19-9, patient symptoms, other factors to incorporate to say that the patient's progressed clearly if felt these patients had progressed sooner. And that number was actually in line with historical controls of around 13 months. And so I think there's still a lot out there to try to figure out exactly where this trial fits. They mentioned that there was a median overall survival. It wasn't the primary endpoint. What I think you were mentioning, Paul, about the outcomes that we're seeing with these adjuvant studies, both the PRODIGE study now and the APEX study, the median overall survival for the GEM control arm was 35 months, which is over a year better than what we experienced with
doing better.
So the other
is the question whether what does that do to? Is it the surgery? I would argue it's the subsequent therapies that we have as options.
Well, also I think it's patient identification.
Exactly.
It's
I agree with John. So I think the big one. So in the APAC trial, they took patients who were put on had a CA19-9 less than 100. Yeah. Now we do CA19-9s post surgery. People have less than 100, but we have a number of patients who are more than 100. So you're selecting. There's a selection bias happening there towards a population. And I do think you could say median overall survival wasn't the primary endpoint, but the median overall survival in GA was 40 months. non-GA was about G was about 36 months. But that's what we're looking at. We're looking at how do you increase the survival of the patients, looking disease survival. So I think we are selecting better. I do think we've made advances. There's no question about it. But I do think, to make further advances, we've got to be self-critical, look at data agnostically, and look at, did we have, we probably had a better patient selection in this trial with a CA99 less than 100 than, than the patients
Sure,
and
it's the best patient.
73 or, that we see with the CA99 at 300 post-surgery, right?